Good afternoon.
Good afternoon. I'm Glenn Raley with Humana, Director of Provider Interoperability.
Dan Wilson, founder of Moxe. And Glenn doesn't realize this, but you missed like a shout out in the beginning where you were introduced as the Fab Five. And the 91 University of Michigan basketball team will always be the Fab Five, but, you know, take it away, Juwan.
All right. So we came here today to talk a little bit about streamlining chart retrieval and some of the work that we've done with partners like Moxe for the benefit of a lot of the things that you all have said, that the people up here have already said, right? Reducing administrative burden, creating economic scale, better patient outcomes, and just the overall member and provider experience improving because of that. And so we'll talk a little bit about that more today.
Yeah, so all the presentations we've gone through so far have some version of getting clinical data back and forth is really important to unlocking value. That is effectively what we do in a very pure play way. We think of it as being a clearinghouse, but for clinical data, where we're looking at how you can unlock clinical data from EHRs, make it available to health plans for a variety of payment and operations programming, but then also close loop back with point of care. And so maybe we can start out a little bit. I think there's a problem set that probably everyone in this room is familiar with in some form, but talk a little bit about when Humana doesn't have access to EHR data in electronic fashion. So kind of the state of the art today, what does that typically look like?
Well, I mean, I get asked the question frequently if we're going to, eliminate chart chase. I was saying, I wish, right? I mean, so the reality is I think that as long as my working career lasts, there will likely still be, people that are not able to do these electronic connections. But as the team from class said earlier today, right, there's really a value in looking at these partnerships and how we change the relationships between the payers and the providers and utilize that technology and the vendor space to get there. So Humana at scale, is bringing in a lot of records, and we still go after a lot of records manually. We still have places that, will send us a PDF via fax, right? We've got a lot of those different solutions, but getting to those really streamlined functions and being able to do that at scale requires the technologies that we're talking about for the outcomes that have already been mentioned by many of the others that came up before, right? Around how do we improve those HEDIS scores? How do we really understand how to reduce technical denials, take process and work and time out of the system, both for the provider community and for Humana?
So the kind of point to the light that we were awarded for is for work that we did with Wake Forest and Norton Health. But this is a program that's being used widely now around the country with Humana. And so it'd be great to hear a little bit about, we've been doing this work since 2017. Why did you start looking for a new way to do this electronically? What have some of the improvements been that you've seen around the last couple of years?
Yeah, and we started really thinking about just how do we get electronic data just in the door, not even necessarily bi-directionally, right? And so through getting more and more one way, we really decided, well, wait a minute, we've got other data that needs to flow back. And so we looked for those bi-directional capabilities. And we know that, there are many solutions out there that are in use by different provider groups. And we're going to have to partner with a number of different solutions so that we can be able to do that for all the Humana membership, because we want those members to have the choice to go to the providers they want to see. And so with Moxe being EHR agnostic, we're able to hit different providers that are on different EHR systems. We're able to do thousands of charts, in an hour instead of, what would take days and days before. And then the usability of that data, how we can bring that and discreetly use it for predictive models and understanding people who are at risk for readmissions and other functions like that. But then also to do so in a way that controls the privacy and really makes sure that it's, security and HIPAA compliant.
And so we talked a little bit already about some of the benefits that you've seen from the Humana side of things. I'll talk about what we've seen from the health system, healthcare organization side, but are there any other specific takeaways?
I think that the biggest one is it is changing that relationship, right? It's changing that relationship with providers who were not in their offices asking for, records the old-fashioned way. We're not doing those technical denials. We're seeing their improved STAR scores. And some of the earlier poll questions I agree wholeheartedly with. A long way, one of the easier ways to get there is through those value-based care partnerships, right? Because there's a vested interest in all parties, and so that easier adoption is there. But we're starting to make way into the fee-for-service space as well, and I think that providers are starting to talk amongst themselves, and we hear feedback around this, well, I heard that you made it easier for these people. Why can't you make it easy for me? And so that's where I think partnerships like Humana with Moxe will continue to grow and find places where they don't have a single AEHR system underneath the covers, or it's one of those ones that we don't have a direct partnership with.
Yeah, and so I think as a practical matter, there were some questions earlier around what were some of the harder pieces in scaling these types of programs out. And I think from our experience, the hardest thing is always just getting somebody to say, yes, I'm willing to start making it easier. And so I think a large part of what's made this successful over the years is the role that both of our organizations have played in actually taking this out into the market and recognizing that even if this is something that Humana or the health plan is underwriting, there's still a very active sales process effectively to help a healthcare organization understand why in the world they would even participate in this in the first place. And so Humana and the network representatives that they have been very active in making that happen, helping kind of message out into the market. I think that's very important to making these types of programs successful. We also have built a very active kind of go-to-market team to go out and actually aggressively try and help healthcare organizations understand why there's benefit in engaging in this type of a program. And so it's been very interesting over the last couple of years to see how the perception has evolved. It was not that long ago that when you went to a healthcare organization and said, we'd like to talk about electronic data exchange, the reaction was, this is going to increase my denial rate. And as you saw in two different presentations earlier today, that's the inverse has occurred. You start sharing this data electronically, it actually simplifies a lot of the payment side of things. What we've also seen healthcare organizations kind of benefit from is that the number one and number two programs for getting this clinical data out to the plans are risk adjustment and quality programming. And with the right contract structure, those are two use cases that will drive revenue into the provider side of the equation as well. So this can be a revenue driving activity. It can ensure accurate kind of payments in the first place, accurate payments. And then there's actual kind of removal of hard costs. So you have your staff costs, your mailing, paper. It's amazing how much ink actually can add up to. So all of that ends up being eliminated as well. I think what we've seen in the last couple of years in particular is that when there's a lot more awareness of, bottom line cost management, trying to manage workforce that has been sent home, staffing shortages, all of these types of things make it harder and harder to continue to do this the way historically we've done it with people. And set up more and more value in transitioning to a electronic model. So I think that's the end of kind of our prepared thoughts, but the clock never started, so we have 10 minutes left. And we are the last one, so no one's going to kick us off, right? Yeah.
Are you seeing any benefits from the standards that are out there, like the EI-275 or the CCD documents out there to help with the change?
Benefits, yes, but I would like to, I think of ourselves as pragmatic followers of standards, so certainly use a standard everywhere you can. But if you think about these use cases that we had on the first slide, the standards today don't typically convey enough information to truly automate the decision-making around a lot of these programs. So what we found, I think, as a practical matter is that you build around the standard, but then you look at any other mechanism required, you do it in as standard of a way as possible, you give your feedback to the standards bodies, you adopt new standards as those specifications come out. You continue to remain on the front edge of that. But if you wait for the standards to catch up, you're going to be stuck doing way more manual chart chase than you'd like to be doing. So I think that a lot of the regulatory focus today is making it so these programs can scale. Like the amount of effort we've had to put in to get to connections to 50, 100, 200 health systems is extraordinary. And I expect that both as the market catches up, the standards catch up, the regulatory framework catches up, those are the types of things that need to occur for this to become a really scaled solution. But we're on the cusp of that.
And I'd add that we certainly have seen benefit from the payer side of standards in that we don't have to support proprietary functions and we don't have to support it with different vendors, right? So all of our vendors are using the same APIs, and those same standards can be applied by the provider systems and by the different vendors. And so I do agree that the standards-based approach is the way to go, but we also have, we always say we want to meet that provider where they are, right? So if the right solution is they only have this information in image, I'll take the image. The image is still better than paper, right? So, so there's a little bit of meeting them where you meet people where they are.
Yeah. Yeah, so it's a good clarification. I always struggle with what language to use. Most of these records are ambulatory records, but we are connecting into these large IDNs that would have hospital and ambulatory setting. But if you look at the demand for data, the risk and quality really is from that ambulatory setting. And so as a practical matter, I think the challenge is that the ambulatory market is so much more fragmented, and so many of those EHRs have not had resources to make real investment for now, in some cases, 10 plus years. And so when you start to look at how do you go and effectively connect into this long tail of ambulatory systems, it does become extraordinarily challenging. That's where I think you look at kind of the emerging standards, the regulatory framework is saying at a certain point, they're no longer going to be compliant systems, or they will have created some new APIs that will make this now possible to scale. So our approach as this kind of EHR agnostic solution is to say, we're going to continue to work with what's available to extend into that longer tail, but we're also making some bets that the long tail will evaporate as consolidation occurs, systems go bankrupt, and these APIs get released.
Incentivize that behavior so that you can eliminate all the other non-standard based. And that's really where I'm looking at the contract.
Yeah, Humana is a large organization. We don't move as nimbly as we might like at times. And many of the benefits that we talked about in the prior slides are what's built into those value-based contracts, right? That's why those value-based contracts exist, is because of the revenue models that are out there for quality and risk and things like that, right? So that's where, to Dan's point, we don't charge any provider organization anything for any of the solutions that we offer. I understand the difference of what you're saying around, is there a more of a point-to-point solution with some incentive model to it. We do have incentive plans that we roll out in certain situations where we're looking to gain a particular system to adopt some of these solutions, where we will incent them. We do have some of the annual wellness visit type incentives. So there's a couple of different ways that we've tried it today. I might pick your ear a little bit later today because I'm curious. I've got some ideas. I don't see any hands, so
We'll wrap it up.
Thank you
Thank
all.
you, everyone.